I would like to thank the organizing committee and Dr. Spargias for the kind invitation for this meeting, which is an excellent meeting, and it's always a pleasure to be here. Just a small comment before I carry on with my presentation. The reason why sometimes we avoid using complete rings is that there's a bit of a technical difficulty. Most of the complications when we implant a ring or a band come from either catching the circumflex or catching leaflets of the aortic valve. Or when a dehiscence happens to the ring, it's usually at the part of the anterior annulus. So the band, which goes only to the posterior annulus, makes the procedure less risky for us and less troublesome. So that's why there has been very growing evidence that for our long-term results, there's not much of a difference whether we're going to put a band or a ring in specific pathologies. However, I'm sure that the technology might help in the future for us to be able to put complete rings or a different type of ring that's going to help transcatheter treatments in the future. And by saying that, it's really nice talk for me to talk about redo mitral valve surgery, something that we don't really talk about, because we don't really talk about our failures. We don't really talk about things that could technically go wrong or things that could go wrong because there is a structural valve deterioration. And my only statement I have to say is that I don't really enjoy doing redo operations, and I don't really enjoy doing redo mitral valves. And that's something that we should keep in mind, and I'm going to explain myself further down my talk, because the thought that what we're thinking about when we talk about redo mitral surgery is, well, can I actually repair a valve that has failed? My first repair has failed. What's going to happen if I have to do a redo replacement? What's going to be my surgical access? And, well, that's a bit provocative, but after a transcatheter treatment, if I have to operate, is it really considered a redo operation or not? What we have to keep in mind, and I really like this paper because this paper is really true world data. It's not sliced or diced or presented in a randomized control trial fashion. This paper from France shows that for primary mitral regurgitation, the repair rates are close to 70%, replacements around 30%. I'm talking about initial operations. It's a bit lower when we are concomitant disease. And it's a bit less when we talk about DMR, SMR, and this paper does not include the endocarditis patients. But what we have to appreciate is that our mortality when we're doing an isolated mitral valve repair is around 1%, and when we're doing a replacement is approximately 6%, 5.8%. We should keep that number in mind when we talk about risks, and when we talk about risks when coming back to redos. This is an old paper. Our repairs are expected to be durable, and especially when we talk about posterior leaflet are expected to be more durable than a mechanical valve. This is an old paper, maybe 20 years ago, which demonstrated well that, well, there are some risks when we do a repair. Anterior leaflet is the worst case scenario, and that's what Antonis presented earlier on. But bileaflet prolapse and posterior leaflet prolapse are actually quite good in the long term. And this has been published and really thoroughly presented by Toronto team, which shows that even after 20 years, the risk of having a reoperation after initial successful repair is at the range of 5 to 10%. So when we're talking about data and when we're talking about jumping to tier treatments to DMR, they should really go all the way after 5 years. They should go all the way to 15, 20 years and see what happens to these patients. And there is some data that actually has data for patients in the 70s and their 80s years old. So there is some data for surgical patients that underwent repair when they were 70 or 80 years old, and they performed quite well, and they reached their normal life expectancy. So what's going on with re-repair? Well, there are some papers which show that usually re-repair is either a technical failure or a progression of the disease. And when we're talking about technical failure, this is almost 40% of the degenerative mitral valve disease that was treated. But when we're talking about rheumatic, well, the progression of the disease is usually the reason why we have to do another repair. What we have to keep in mind is that there is a 43% risk of recurrent prolapse. So usually when the primary repaired valves fail, usually there's a technical problem, there's a new prolapse again, not much of a progression of the disease. And when we talk about rheumatic disease, though, it's a progression of the disease itself, is not a failure of our repair. When did this happen? most of the papers show that when we have to do a reoperation, usually is approximately 8 years after the first operation. So it's not something that happens over the first 5 years on average. Of course, there are patients who were operated really, really early. Now, we move on. Another paper, again, which shows more or less that when we have to do, most of the surgeons usually replace when there is a new regurgitation of the mitral valve. Most of the patients usually repair when there is a hemolysis. When it's endocarditis, usually we replace the valve. And where there's an annuloplasty problem, usually the Hissens, we try to re-repair it with some extra stitches. So this gives us an idea of when we should re-repair the valve in order to have good results. And there are some papers which show that actually re-repairing improves survival. However, this paper was a bit, the numbers were not great and many patients were lost to follow-up. However, it showed that re-repair may be safer in terms of long-term survival at 5 years compared to replacement. There are big meta-analyses, well, not really big, but anyway, it had 5 or 6 papers which showed that this might not be statistically significant together with other comorbidities, morbidities like stroke, etc., and so on and so forth after re-repair versus re-replacement. So there might be a trend, let's say, towards safer outcomes when we have to re-repair. What about replacing the valve when we first have already replaced the valve? Well, the mortalities actually are not that bad. And this paper shows that if we go from isolated mitral valve replacement, we exclude endocarditis, we exclude concomitant procedures, and we do another mitral valve replacement, the mortality actually is around 6.9%. On a baseline of 4.1 on the first operation, non-statistically significant. And if you remember, it's actually more or less close to the mortality of the first operation. What you have to keep in mind again is here, the mean reoperation time was approximately 10 years, and almost 45% of the patients had mechanical valves. So mechanical valves do not last forever. Actually, they might need, and there is a good chance they might be needing to be replaced, either because they thrombose or either because they develop panos. So we should keep in mind that even mechanical valves have a failure rate. And as I said before, there was not much of significant difference in the mortality at a really long follow-up of these patients compared to the first surgery, and there was not much of significance in other morbidities that were examined. I was really happy to contribute to this paper. This paper is a bit of a different paper because it included absolutely everything. All the patients that had redo mitral surgery, even if they have endocarditis, even if it was a second or third time redo, even if you have to do concomitant procedures like aortic valve replacements or bypass grafts. On this particular group of patients that we did in Southampton a few years down the line, it shows that hospital mortality is a bit bigger. It goes up to 12%, and on follow-up is also quite big, and the morbidity is quite significant, with patients having to stay a bit longer to hospital. So we have to take into consideration these patients that are a bit sicker, these patients that need to have a second or a third operation or need a concomitant operation. These patients have a bit of higher risk of mortality compared to the ones that just need another isolated mitral valve replacement. When it comes to access, we've seen the excellent talk by Antonis earlier on, but there have been some evidence, even this paper is 25 years old, there have been some attempts, let's say, to do the redo mitral operation from the side of the chest to avoid a stenotomy. And there are some technical considerations that are involved, and this is whether the first operation was done again from the right chest or whether it was done through a stenotomy, and there are some technical difficulties and the risk of conversion. And we have to think about myocardial protection and how it's going to happen, whether it's going to be fibrillation or cross-clamp or balloon, and whether there's any benefit to that. And I'm afraid I don't have the answers to all these questions, because sometimes you get in a really stuck lung around the pericardium, and you get really stuck on the Watterson groove when you try to access the valve again. So it's a bit of a pain, and there have been many series published, but there is this paper that was published recently which tries to compare a redo operation with a robotic assistance versus a conventional stenotomy. And if you see the numbers, basically it showed not much of a difference. So it doesn't really make much of a difference whether it's going to be a stenotomy or whether it's going to be a robotic access when you do redo surgery. There are some minor differences when it comes to operation time, etc., but nothing really in terms of hard outcomes. The previous paper was about robotic. There is a paper, again, that was published for redo endoscopic mitral valve surgery, which showed much better results. This paper is from Alst. Again, very experienced hands and very experienced sensors. And now, what's happened after? Well, there are some patients that after a mitral clip, let's say, end up having an operation. I don't know how frequent is that, probably not very frequent, but is this considered really a redo? It has a high mortality, I have to say, because these patients are quite sick, and we know that we don't really do TEERs in really, really young or really, really fit patients with the DMR. However, these patients that ended up being operated had really high in-hospital death and really high cerebrovascular accidents, and 1/4 of them was dead by the end of the year. And the operations were really hard. People had to replace the valves, and they needed a long hospitalization and long ICU stay. So before we jump doing mitral clips on somebody who's really young and fit, maybe we should consider what's going to happen if this clip fails in the long term, because really the operation then might be more riskier than doing a redo, say, a conventional operation on the mitral valve. And some more data with regards to what I said previously. Detachment is more frequent, I think, as a part of complications when it comes to mitral clips and endocarditis, which is not that often, I think. However, I still don't like redo mitral surgery, and that's I'm just finishing now, which has some key technical considerations that I have to keep in mind. These patients need to be very well addressed. They need many examinations. They need to have CT scans, and we need to have a very, very good strategy when approaching them in terms of how we do the incision, how we go on bypass, how we protect the heart, whether we're going to be replacing or repairing the valve. And there are so many details that one has to take into account. That's why these are quite complex operations. That's why the heart team comes into discussion with the new technologies emerging and the new generations of clips and transcatheter valves. So redo mitral surgery is not as high risk as one may think, but needs careful planning. Re-repair may be possible and may be safer than re-replacement. Mortality for redo isolated MVR after isolated MVR is close to the risk of the first operation. Complex concomitant cases add to the risk, as we said earlier. Minimal access surgery may be possible, but we don't have any proven benefit yet. And surgery after a failed TR is very high. So the heart team approach is mandatory. Thank you very much.
Thank you, Dr. Barakis. Congratulations. Any questions? Yes, Professor Kelly.
Maybe we can make a comment for failed transcatheter H2H therapy. Really, sometimes there can be some problems if we put, for example, 2 devices or 3 devices after endothelialization. Residual gradients can occur, and the ELASTA procedure is the only procedure that we had to do these patients. But for the removal of the mitral clips, some new novel devices are developed, like UNO device and the other ELASTA procedures, but it still needs surgical backup. This is very important. So heart team approach is the most important thing, both before evaluation and, for example, in the last 3 presentation, a lot of comments about functional mitral regurgitation and the other things. We always think about this now, atrial functional mitral regurgitation or ventricular functional mitral regurgitation, but as a surgeon perspective, for example, do you think all these, atrial mitral functional, ventricular mitral functional, as a surgeon, do you think all these mechanisms when you are repairing the mitral valve?
Of course we do. And I think when we try to repair the valve, in order to have good results, you need to have a good plan before you actually enter the operating room, and you have to study the patient really well. Because it makes a huge difference if you operate on a patient who has a primary with a flail P2 compared to a patient with an ischemic ejection fraction 35% and tethering, and what you're probably not going to repair, but you're going to replace. Since you mentioned the atrial MR, I think this is probably something that's one of the easiest valves to repair for us, because usually you just have to put a ring in the mitral position. Usually these patients need also a ring in the tricuspid position, and you sort out the problem. And for not young, but I would say for low-risk patients, this might be the case because we can do it very easily endoscopically, and 2 rings is actually quite good. At the same time, we can do even ablation if it's needed, but usually these patients have quite big atria, or we can exclude the left atrial appendage. So I think there's a lot of discussion that needs to be done, especially for these patients that are on the margin. For most of the patients who have secondary mitral regurgitation, especially when this is ischemic or we have really dilated ventricles, probably the transcatheter treatments are better, and this is where the trend is going, and we're really happy about that because these patients were really sick. However, when it comes to primary mitral regurgitation, these patients are younger, are less sick. It's much more difficult to have a transcatheter device to compare with surgery. For the atrial mitral regurgitation, I think we're in a gray zone. The patients that get referred early probably would benefit from operation. The patients who are actually quite symptomatic and with ventricles that are with low ejection fractions down the line probably do better with transcatheter treatments. So that's the short answer, I think, to your question.
I asked this provocative question because we should also know what's going on surgical part. Because we are only focusing sometimes for transcatheter part, but surgery is also can be done in a lot of cases. Thank you.
Thank you.
I just want to say now that we have the surgeons with us that we need you because, as you saw, the SLDA in the mitral valve is approximately 3% or 4%, and the tricuspid valve is even more. An SLDA doesn't necessarily mean that the patient needs to go to surgery and that he will have a problem. Sometimes we may save some SLDAs by additional devices, but a large proportion of them will need surgery. And then you come into play and you must optimize the way you correct this valves. I understand this is much more difficult than having the valve from the beginning.
Yeah.
But I suspect that the next generation devices will have sensors to tell us if the leaflet is inside or not. So I suspect that this failure of the SLDA will go down with the next generation devices. But certainly it's still a problem. We shouldn't play down this problem. We shouldn't underestimate it. And that's why we need the heart team work, like Theo said, to discuss from before which is best for the patient. And if something goes wrong, then we'll also together know how to correct it.
And I think we should think also both ways. Sometimes we have this 40-year-old female that wants to have, that has a P2 prolapse. It may be better to have an operation first endoscopically, and then if something happens and there is another relapse, she can be treated with a mitral clip maybe, and you still have the ring in place. So these outcomes may also be good. So I think, as you said, the technology is developing, so we should cooperate in cases and discuss which is going to be the best way forward, even in the mitral valve.
Okay, thank you.
Just the last comment. I think DMR is a surgical therapy.
It is. Yeah.
Like Naso said earlier, this hasn't changed. So in DMR, the first thing that comes in our mind when we see the patient is surgery. The only case for DMR to go for a clip is older age or really high risk. Otherwise, we wouldn't. But the same style should be like FMR cases automatically go for TIA,
Totally agree.
because unless they have another reason to go on the operation table, like a coronary bypass or something. I think this remains the same.
That's true.
Nothing has changed to this holoscopic approach. Thank you.